Bismillahirrahmanirrahim. I'm Dr. Humaira Khan. I'm a consultant radiologist working in Birmingham, UK. My topic of presentation is ovarian cancer diagnosis. So I'll be talking to you about what ovarian cancer is, some statistics, risk factors, means of diagnosis, and treatment. Okay. So ovarian cancer is the second most common gynecological malignancies and is the fifth leading cause of cancer death in women. Now, despite significant advances in cancer diagnostics and treatment, ovarian cancer continues to kill more than 150,000 women every year worldwide, and it is the most lethal of all gynecological malignancies. Nearly 75% of women with ovarian cancers present with advanced stage disease, which is stage 3 and 4, and is associated with poor prognosis. Due to the relatively asymptomatic nature of this cancer and the advanced disease at the time of diagnosis, there is a need for improving methods for early detection of this cancer. The other issue for patients' outcome is response to chemotherapy. Since ovarian cancer is a heterogeneous disease with respect to the histological subtypes, molecular biology, and disease prognosis, a single standard treatment is unlikely to benefit all patients. That is, a single size fits all is not going to work in these cases. Risk factors. The most common risk factor is age. Ovarian cancer is common in postmenopausal women. Family history. Luckily, 80 to 85% of ovarian cancer cases are sporadic. That means they do not have a family history. The remaining 15 to 25% of cases are believed to be caused by an inherited faulty gene, which is often associated with BRCA1 and BRCA2 gene. Family history of ovarian, breast, endometrial, or colonic cancer is also of particular interest. So the greater the number of affected relatives and the closer the degree of relationship, the greater the risk of having ovarian cancer. In some cases, the relative risk is 40 times greater. Obesity is another risk factor, infertility, hormone replacement treatment, and endometriosis, to name a few. So if it is such a lethal condition, do we have any screening tests for that? Now, as you can see from the slide, the prevalence of ovarian cancer is 1 in 75. So it has a relatively low prevalence rate within the general population, and there is no proven precursor lesion that exists that can be detected and treated to prevent the cancer from occurring, which is contrary to what happens in breast cancer, where the risk is 1 in 8. So we have got screening programs available for breast cancer. Ovarian cancer has no approved screening method at this time. All the screening with serum CA125 levels or transvaginal ultrasound can detect ovarian cancer at an early stage. These are not very specific, and they do not decrease mortality from ovarian cancer. In addition, because of the invasive nature of the diagnostic testing and the potential harms from the false positives, these outweigh the potential benefits. Types of ovarian cancers. So ovarian cancers are classified on the basis of the cell of origin into epithelial, germ cells, sex-cord tumors, or malignant types. Epithelial tumors account for nearly 85 to 90% of all malignancies. And these are further subdivided into 5 types by order of frequency. So these are the high-grade serous carcinoma, which accounts for 70%, endometrioid and clear cell cancer accounting for 10%, mucinous cancer accounting for 3%, and low-grade serous carcinomas. And these arise from the epithelial lining. So the other ones are the germ cell cancers, which arise from the germ cells, and the stromal cancers, which arise from the stroma of the ovary. So classification of ovarian tumors. So the epithelial cells, and then we have the germ cell cancers, which account for 50 to 20% of all these cancers, and these are the teratomas, dysgerminomas, endodermal sinus tumors, and choriocarcinomas. Then we have the sex cord tumors, which arise from the stroma of the ovary, and these are usually benign. And these are the fibromas, granulosa theca cell tumors, Sertoli Leydig cell tumors. And the rest of the tumors, which account for 5% of ovarian malignancies, are the metastases. In advanced stages, regardless of the type of cancer, all tumors have similarly poor prognosis. Coming to the diagnostic tests, we start with the history of the patient, physical examination, tumor markers, RMI, and imaging tests. Symptoms of ovarian cancer, these are very vague and very non-specific. Most of the patients present with persistent bloating, abdominal distension, unintentional weight loss, feeling full very quickly, fatigued, and urinary urgency and frequency. Physical findings, again, are very uncommon in early stage disease. Patients with more advanced disease may present with any of the following, like abdominal or pelvic mass, distension due to ascites, pleural effusion, or bowel obstruction. Tumor markers. So what are tumor markers? These are chemicals or proteins which are given off from the surface of the cancer cells, and they circulate in the bloodstream where they can be measured. Now, they are very helpful for both establishing the diagnosis and monitoring the response to treatment. There are different types of tumor markers which are raised in different types of ovarian cancers. For example, CA125 is increased in epithelial cancers. CEA is raised in mucinous cancers. HCG is high in embryonal and choriocarcinoma. Inhibin is raised in granulosa cell cancers, lactic dehydrogenase in dysgerminomas, alpha-fetoprotein in endodermal sinus tumors, and embryonal carcinomas. So there are tumor markers, and there are cancers which are more common in certain age groups. So in women less than 30 years of age, these sex cord tumors and germ cell tumors are more common. So in this age group, we will request tests for alpha-fetoprotein, HCG, LD, and inhibin. In age group 30 to 50 years, we usually request inhibin, estradiol, testosterone, and CA125. Whereas in postmenopausal women, because the chances of them having epithelial cancer are more common, so we request CA125, CA19.9, inhibin, and CEA. CA125 is very important. Now, this protein is present on the surface of the ovarian cancers, but it is also found in normal tissues. The normal CA125 level in blood is measured as 35 units per milliliter to less. Elevated levels are found in 80% of women with ovarian cancers, mainly the epithelial cancers. However, it is also raised in other cancers like the endometrial cancer, cervical cancer, breast, lungs, GI malignancies, and more importantly, in many non-cancerous conditions like menstruation, pregnancy, pelvic inflammatory disease, pancreatitis, peritonitis, to name a few. CA125, therefore, is very non-specific and so used mainly for monitoring the treatment response. Increasing and high level of CA125 in a patient with ovarian cancer mean progressive disease or recurrent disease, whereas decreasing level is a good sign of response to chemotherapy. Now, what is RMI? RMI stands for Risk of Malignancy Index, and it has a very simple formula. RMI is equal to U times M times CA125, where U stands for ultrasound findings, M stands for menopausal status. It is a validated clinical tool which is used for risk stratification of ovarian lesions to guide further management. So how do we interpret it? So M is very simple. We give a score of 1 if it's premenopausal status and a score of 3 if it's postmenopausal. U score is 0 if there are no features of malignancy on ultrasound. It is 1 if there is one feature of malignancy on ultrasound, and it is 3 if there are 3 or more features of malignancy. And what are the features of malignancy on ultrasound? Irregular solid multiloculated cystic mass, for instance, solid components in the cyst wall, very strong color flow on Doppler, ascites, peritoneal nodules, and evidence of metastasis. So these are the features of malignancy on ultrasound scan. Now, how do we interpret when we combine them together? When you multiply them together and you get a score of greater than 200, there is a very high risk, around 75%, that the woman is suffering from ovarian cancer. These patients will then have to be referred to a specialist gynecological cancer service and should be staged with CT scan. An RMI score of between 25 to 200 means intermediate risk of having ovarian cancer, around 20%. An RMI of less than 25 means the patient has a very low risk, that is less than 3% of having ovarian cancer. Coming to this staging of ovarian cancer. So it has 4 stages. Stage 1 means it's localized to one ovary or both ovaries, or the capsule has ruptured and the cells have now spilled into the peritoneum, leading to ascites. Stage 2 means there is now infiltration into the surrounding structures, like into the fallopian tubes, the uterus, bladder, rectum, sigmoid. Stage 3 means it has now moved further into the retroperitoneal lymph nodes and also into the mesentery and into the peritoneum in the form of peritoneal deposits. Stage 4 means the tumor has now spread outside the abdominal cavity. It has gone into the lungs, or there is visceral involvement like liver metastasis, splenic metastasis, bony metastasis, for instance. This is a study that was performed by Cancer Research UK, and it shows that the survival rate in stage 1 is more than 90%, whereas survival rate for stage 4 is only 6%. That's why it is important to diagnose it at earlier stages for better prognosis. The most accurate staging of ovarian cancer is based on the findings at exploratory laparotomy. And what is an exploratory laparotomy? A complete staging exploratory laparotomy includes hysterectomy, bilateral salpingo oophorectomy, with omentectomy, random peritoneal biopsies, and sampling of para-aortic lymph nodes. Routes of dissemination. The most frequent route for dissemination is by direct extension into the surrounding organs or through the transcoelomic peritoneal route. Second route is through the lymphatics, starting from the pelvic lymph nodes, moving up into the retroperitoneal lymph nodes, para-aortic nodes, and then upwards into the mediastinal nodes and supraclavicular nodes. Heterogeneous metastases are the least common, and they most frequently occur in the liver, lungs, bone, and the brain. Coming to imaging. What are the imaging modalities that can be used for diagnosing ovarian cancer? We always start with ultrasound, CT, MRI, and PET scan. So ultrasound is the modality of choice in the initial evaluation of a patient with suspected adnexal mass. It is low cost, it is very fast to perform, easily accessible, and we have no radiation hazards. Compared to transabdominal ultrasound, transvaginal ultrasound has a much higher resolution. The problems with ultrasound is, however, that it has significant inter-observer variability in the interpretation and assessment of images. So it is operator dependent, and it is also device dependent. It cannot be used in obese patients because of poor resolution. It has limited field of view. It is only good for visualizing soft tissues, cysts, and fluid, but cannot be used for bony structures or for bowel. So because of these problems, it was felt that it will be very useful to have a common terminology and some set standard parameters for the sonographers so that all sonographers will interpret the imaging findings as the same. This idea was proposed by International Ovarian Tumor Analysis Group from Belgium, and they devised a system called simple rules. If we use the simple rules, the sensitivity in differentiating between benign and malignant masses increases to 90% and specificity to 93%. Now, this software is available free of charge at the IOTA website, and application is available for both the Android and iOS devices. So it's free to download. And how does it look like? So what they have done is they have looked at thousands and thousands of ultrasound images of patients with benign adnexal masses and malignant adnexal masses. Most of the characteristics that overlapped these two conditions were taken off, and then they selected 5 very specific characteristics of benign masses and 5 characteristics of malignant masses, and they came up with this simple rule. So for a lesion to be benign, they should have one of the 5 features from the benign category and none from the malignant category. And similarly, for a lesion to be malignant, it should have one or more of the features from this malignant category and none from the benign category. So what are the benign features? Benign features is a unilocular cyst. It is a cyst which can have a solid component but less than 7 millimeters in size, a lesion which has got acoustic shadowing, a multiloculated cyst but with a diameter of less than 10 centimeters, and a mass which shows very little or no flow on Doppler. Malignant characteristics are an irregular solid mass, presence of ascites, presence of at least 4 papillary projections in a cystic mass, an irregular multilocular solid tumor with a diameter of more than 10 centimeters and very strong Doppler flow. These simple rules can be applied to at least 70% of all cases, which can then be correctly classified as benign or malignant with a sensitivity of 93% and a positive and negative predictive values of 80%. Around 25% of these adnexal masses, however, will still remain indeterminate because they have got overlapping features of benign and malignant. And therefore, in this condition, the patient should be referred to a specialist and other staging tests will have to be performed. In a nutshell, a unilocular simple cyst of less than 5 centimeters is seldom malignant, even in postmenopausal women. This is very important to remember. A multilocular cyst with thickness of 3 millimeters, with septations which are thicker than 3 millimeters, multiple papillary projections, have got features which are suggestive of ovarian cancer. The single most predictive ultrasound feature of malignancy in a cystic mass is the papillary projections. Moving on to CT scan, it has got excellent soft tissue resolution for bones as well as for vessels. Machine is open, so it can be used for claustrophobic patients and even for obese patients. It can be used as a multiplanar imaging. However, compared to ultrasound, it is more expensive. There is radiation involved, and patients can suffer from contrast reactions. It is, however, extensively used in the staging of ovarian cancer. A preoperative CT is crucial in identifying patients who are potential candidates for optimal debulking surgery. What is the optimal debulking surgical procedure? A procedure that leaves the patient with less than 1 centimeter maximal diameter residual disease is considered optimal debulking procedure. It is associated with a more favorable response to postoperative chemotherapy and, of course, prolonged survival. A multi-detector CT scan has a sensitivity of 97% and specificity of 91% in differentiating between benign and malignant masses. It has an accuracy of 94% in preoperative staging of ovarian cancer as well. It is used to identify sites of disease that are difficult to assess at debulking surgery. For example, the surface of the diaphragm, the lesser sac, mesenteric root, splenic hilum, and the paraaortic nodes above the renal vessels. It is also used to evaluate distant metastases like the pulmonary metastasis and mediastinal lymphadenopathy. This is an example of a CT scan with three different planes, the axial plane, the coronal plane, and the sagittal plane, showing a large malignant-looking adnexal mass with gross ascites. And you can see this in all three different planes. Now, this picture shows the sites of potentially resectable disease, potential non-resectable disease, and non-resectable disease. So the boxes in yellow are the sites of potentially non-resectable disease, and the boxes in red are the sites of non-resectable disease. For instance, a plaque-like disease below the diaphragm of more than 2 centimeter thickness, if described on CT, means that this is a non-resectable disease, just like liver and splenic metastasis, diffuse large volume disease in the mesentery, high retroperitoneal nodes above the celiac axis, bony and muscular pelvic metastasis. These are all sites of non-resectable disease, just like pleural effusion and paracardiac lymph nodes. The sites of potentially non-resectable disease are at the porta hepatis, lesser sac, falciform ligament, in the gastrosplenic ligament, lesser omentum, rectal and sigmoid serosal disease, and ureteric invasion. This is an example of a 66-year-old woman with a right adnexal mass, which extends into the pelvic side wall and encases the iliac vessels. So when the distance between the mass and the pelvic side wall structure is less than 3 millimeter, we say that this is pelvic side wall invasion. This is another example of an 80-year-old woman with stage 3C papillary serous adenocarcinoma. This is the mass here in the pelvic. It is causing the bilateral ureteric obstruction, and this can be seen as bilateral hydronephrosis. There are also multiple peritoneal deposits and deposits on the surface of the liver. This is an example of a 64-year-old woman with stage 3C serous carcinoma. CT shows non-resectable disease because there is confluent more than 2 centimeter mass of peritoneal disease under the surface of the diaphragm. So if CT reports these features, this would alert the surgeon that this is non-resectable disease. So instead of having surgery, the patient would then undergo chemotherapy, and when a repeat CT shows that the disease is getting better and showing response to treatment, then the patient will undergo surgery afterwards. So that is called neoadjuvant chemotherapy, meaning chemotherapy given before the surgery. This also shows non-resectable disease at the porta hepatis and the gastrohepatic ligament as well. Now, this picture shows how omental disease will look like on clinical inspection in the form of large bulky masses, which we call omental cake. This is how omental cake looks like on clinical examination, and this is how it looks like on CT, a large block of disease just under the anterior abdominal wall. With regards to lymphadenopathy, so this image now shows large volume, more than 2 centimeter, non-resectable disease in the lesser sac and also in the gastrosplenic ligament, along with ascites around the liver. Mesenteric disease. Now, detection and extent of mesenteric disease is particularly important to document, as it usually precludes surgery in most of the institutions. Mesenteric disease is most frequent in the right lower quadrant and in the root of the small bowel mesentery, very close to the terminal ileum. This is how it looks like on a CT scan. Now, this is a 66-year-old woman with stage 4 serous cystadenocarcinoma. There is diffuse, irregular, infiltrative disease that occupies most of the mesentery and cicatrization of the small bowel loops, which seem to be tethered to this mesenteric mass. And in addition to that, there are multiple small scattered mesenteric nodules as well. All this signifies non-resectable disease. Lymphadenopathy. The preoperative detection of lymphadenopathy allows the surgical modification to then include the retroperitoneal lymph nodes, which are normally not performed at the time of surgery. And this could be in the form of a two-part procedure or extended single surgical procedure. At present, the nodal short axis diameter of 1 centimeter is used to suggest malignant lymphadenopathy. Diffuse retroperitoneal lymph nodes in the suprarenal distribution again should be highlighted to the surgeon because that precludes surgery. And detection of pericardiac nodes more than 1 centimeter also precludes surgery as it confers poor prognosis. This is an example of a 73-year-old woman with serous cyst adenocarcinoma. It shows extensive non-resectable disease. This is the aorta, and this is soft tissue mass of matted lymph nodes encasing the aorta and an enlarged pericardiac node. This is irresectable stage 4 disease. Visceral metastasis. True hematogenous parenchymal metastases are very rare at the time of presentation. Invasive serous surface implants are the most frequent mode of parenchymal involvement of the liver and of the spleen, and these may then invade into the underlying parenchyma. So surface hepatic implants can be easily strummed at surgery, but the deep implants will require partial segmental or lobar hepatectomy, and the extent of surgical resection requires preoperative liaison with a hepatobiliary surgeon. Implants into the Morrison pouch, which extends to the hepatic porta hepatis and the IVC, also increase the risk of suboptimal resection and intraoperative bleeding. This is the example of a subcapsular deposit, which then are also extending into the liver parenchyma here. And this is something that has to be communicated to the surgeon because it will require assistance of a hepatobiliary surgeon for segmentectomy or lobectomy if required. Bowel metastasis. The involvement of bowel is frequent in advanced disease and occurs to direct invasion from the pelvic cancer. It can also occur along the mesenteric fascial planes, through the lymphatics, through intraperitoneal seeding of the tumor, and through embolic hematogenous metastasis. It is a most common cause of ovarian cancer-associated morbidity. This is an example of a 58-year-old woman with a stage 3 undifferentiated cancer showing extensive small bowel involvement by the cancer, which then leads to dilatation of the small bowel, which signifies intestinal obstruction. MRI scan. Both MRI and CT have been shown to be equally effective for staging advanced ovarian cancer, but MRI has got a few limitations. Cost implications, because MRI is most expensive of ultrasound and CT. It has a longer acquisition time. That means it takes longer to perform an MRI scan, whereas CT can take up to 10 minutes for doing the whole body CT. MRI can take up to 45 minutes or more. And because of this long time, there are also resultant motion artifacts, which will reduce the quality of the images. Then there can be issues with reaction to gadolinium, which is the contrast that is used for MRI scans. It is also not good for assessing the bones or the lungs. MRI also has contraindications in patients who have pacemakers, who have metallic clips, or who are claustrophobic. However, MRI is used as a problem-solving tool in sonographically indeterminate ovarian masses by providing better tissue characterization. It is also extremely accurate in diagnosing benign lesions like mature cystic teratomas because they contain fat, endometrioma as they contain blood, and some subserosal leiomyomas that can also mimic ovarian mass. PET scan. PET scan uses 18-fluorodeoxyglucose. The role of PET scan in diagnosing and staging ovarian cancer is controversial. Borderline and early stage ovarian cancers can be falsely negative on PET imaging due to very small amount of FDG avid tissue. And false positive results also arise from inflammatory processes and benign ovarian tumors. Therefore, it is used for problem solving and also in evaluating recurrent ovarian cancer when CT and MRI is negative despite a rising CA125 level. So this is how a PET CT looks like. It is showing this cystic ovarian mass on 3 different planes. There are certain organs which have a physiological uptake of FDG, like the brain and the heart, and also the bladder. This is another example of a PET scan which shows extensive, avidly enhancing retroperitoneal lymph nodes and also nodes in the supraclavicular region which could have been missed on a CT scan. This patient then underwent an ultrasound examination and a lymph node was found and it was positive on histology. Now coming to the management of ovarian cancer, standard treatment is debulking surgery followed by chemotherapy. The aim of cytoreductive surgery is to confirm the diagnosis, define the extent, and resect all visible tumor. But neoadjuvant chemotherapy is now increasingly being used as well in advanced stages. The type of procedure will depend on whether the disease is visible outside the ovaries. So when there is no disease visible outside the ovary and the lesion is not greater than 2 centimeters, the patient requires formal staging, surgical staging by multiple peritoneal biopsies, omentectomy, and periodic lymph node sampling, along with salpingo oophorectomy and hysterectomy. If there is visible disease outside the pelvis and in the abdomen, that requires aggressive surgical debulking with the intent to remove all visible tumor. If the surgeon determines that optimal debulking surgery is not possible based on the CT findings as well, then neoadjuvant chemotherapy should be considered. So there are 2 different options. The option 1 is for the patient to have surgery, primary debulking surgery, and then 6 cycles of chemotherapy. And option 2, if the disease is very extensive and advanced, is to start off with 3 cycles of chemotherapy prior to the surgery, which is called neoadjuvant chemotherapy, followed by surgery, and then 3 further cycles of chemotherapy. And all of these chemotherapies would be followed by a CT scan to assess response to chemotherapy. With regards to chemotherapy, it is indicated in all patients with ovarian cancer, except those who have surgical, pathological, stage 1 disease and low risk characteristics. So the standard post-operative chemotherapy for ovarian cancer is a combination therapy with a platinum compound and taxane. So example, carboplatin and a paclitaxel. So this was all about ovarian cancers. There are other conditions that can mimic ovarian cancers. 2 of the more commoner ones, and the one which can be more embarrassing for a radiologist is a over-distended urinary bladder. We come across many patients who have had an ultrasound scan, and the scan suggests a large cystic mass in the pelvis, which then turns out to be an over-distended bladder. And also sometimes a fecal loaded bowel also mimics an ovarian mass. So these are the two differentials that we should keep in mind when performing ultrasound scan and also on a CT. The other differentials would be appendiceal cancers, colonic cancer, GI cancers, because they also cause omental cake when they metastasize, hydrosalpinx and parasalpinx, ovarian torsion, pelvic kidney, and peritoneal cysts, just to name a few. Okay, in conclusion, ovarian cancer is a silent killer. It does not have specific findings and detected quite late. If it is detected early, the 5-year survival rate is greater than 92%. However, unfortunately, 60% of these women are diagnosed at an advanced stage. Detection is difficult just by the history and by the physical examination. Therefore, imaging has a very important role to play. The role of imaging is threefold. It is detection, characterization, and staging. Preoperative staging by imaging is also crucial to identify those patients who are potential candidates for optimal debulking surgery. There is no effective screening yet, so patients have to stay on top of the symptoms. So what does the gynecologist want us to know? It is difficult to detect, so knowing history is very important for the patient. Treatment also varies. The symptoms are very non-specific. The prevalence is not that high. It occurs in 1 in 78 women, and that was it. So this educational activity is supported by JSMU ANA, and below that is my email address. If you have any queries regarding this lecture or anything related to ovarian cancer management and diagnosis, you can contact me on this email address. Thank you.